Good evening, everyone. So today, NCSI team is coming up with a panel discussion on a very important topic, that is end of life care, and where there are more dilemmas than the clarity. And we have some eminent speaker who are working exclusively in this area, and they are there to shade light and share important information with all of us, which certainly should help us moving forward. We have Dr. Keshav as a moderator. I think he doesn't require any introduction. Welcome, Dr. Keshav. So he is working as a professor at AIMS, New Delhi, and he's playing a very important role in the NCSI as well as in the ISNAC societies. Dr. Keshav will be moderating this session today, and I request you to introduce our panelists and take the session ahead, Dr. Keshav.
Uh, Thank you, Dr. Rohini, Dr. Ashish, and the E-Education Committee of the Neurocritical Care Society of India. A very good evening, all. On behalf of the Neurocritical Care Society of India, I welcome you all to this ethical and legal aspect of end of life care, and especially in that we will be discussing on the neurocritical care aspects of end of life care in this seminar come panel discussion. So at times the medicine is powerless in patients, those who are overmastered by this disease. And here the point comes where we should go for the, instead of curative treatment, we should go for the comfort care, the palliative care to have a good death. As far as the quality of death score is concerned, we fare poorly as a country. Still, there are many terminal discharges which are having in the terms of LAMA and DAMA, which is contrary to the current practice in the world, where almost 90% of the cases the decisions to limit treatment are taken in the ICU. But yes, we have made a significant progress since this landmark judgment and landmark case of Aruna Shanwag in 2011-2012. We had 2018 where the Common Cause versus Union of India, they gave us some protocol, some formulation which was very complicated. And over the years in 2023 January, it was much simplified. And we are fighting for more. So to discuss all this, we have today's esteemed panelists with us who have given their sweat and blood to this, and they are so passionate about this end of life care. So it is my proud privilege to welcome Dr. R.K. Mani sir, who is the man of the end of life care. He is so passionate about this, and he is the chairman of the end of life care in India task force. And currently, he is the director of the clinical services, pulmonary and critical care at Yashoda Hospital, Ghaziabad. Welcome, sir. Next, we have Dr. Sushma Bhatnagar, ma'am. She is the chief of cancer center at AIMS. She is the professor and head of the onco anesthesia and palliative care medicine at AIMS. She has been instrumental in giving the institutional guidelines of AIMS way back in 2022. And these two stalwarts have given a very good must-read paper on end-of-life care, which has come in the Indian Journal of Critical Care Medicine. So they have given the position statement and the expert consensus panel on end-of-life care. So welcome, ma'am. Next, we have Dr. Jitendra Sharma, sir, who is the Chief Intensivist, Artemis Hospital, Gurgaon. He has been passionately and practically dealing with the end-of-life care scenarios in his day-to-day practice. We'll hear him. Doctor, welcome, sir. And next, we have Dr. Kritika S. Rao, the young and dynamic associate professor in the Department of Palliative Care Services at Kasturba Medical College, Manipal. She has a special interest in neuropalliative care, and she's running an international course on the neuropalliative care. So she's welcome here. So without much ado, I will hand over the mic to Dr. R.K. Mani sir, who will tell us what is end of life care, what are the basic principles of end of life, what is the difference between withdrawal and withholding, if any, and what are the current protocol and the current steps and status of the end of life care. Over to you, sir.
Good evening to all of you. So we'll discuss the medical and practical aspects of EOLC practice in the ICU and hospitals. Next. What is end of life care? This is a very fundamental question. It's an approach to a terminally ill patient that shifts the focus of care to symptom control, comfort, dignity, quality of life, and quality of dying, rather than treatments aimed at cure or prolongation of life. So you see, there's a shift of focus here from cure to caring and to the needs of the dying, rather than just requirements directed at disease control. And palliative care relating to EOLC is a holistic approach to treatment that improves the quality of life of patients as well as families facing the problems associated with life-threatening illness through the prevention and relief of suffering. So again, the stage moves from cure to suffering. Now, death has come to be like this, very lonely, surrounded with these machines rather than with family in our modern times. And surveys in Europe have shown that 1/3 of patients in the ICU, 1/3 to 1/4 of the patients are receiving disproportionate care they don't need, care that may not only not help but even harm in terms of increasing suffering and prolonging death. Next. So the underlying principles of EOLC in a nutshell are respect for patient autonomy, but that is not all. There is adherence to physician duties of beneficence, non-maleficence, and distributive justice, which we have to incorporate in this approach to EOLC. And how does it happen? It happens through communication, which should be open, honest, timely, and compassionate. And then there has to be within the framework of the law of the land as compliance with legal requirements. And of course, which needs transparency and documentation, and then timely transitioning to palliative care. Next. So graphics of withholding and withdrawing are these. You can see that withholding is not starting an intervention at all. And withdrawing is once started an ongoing intervention, it is stopping and not restarting. This is withdrawing. And next, the definitions are withdrawal is a considered decision in a patient in a patient's best interest to stop or discontinue ongoing life support in a terminally ill state that is no longer likely to benefit the patient or is likely to harm in terms of causing suffering and loss of dignity. 3 conditions must apply. Medical prognostication and considered opinion that patient's disease condition is advanced and not likely to benefit from aggressive interventions. Patient surrogate documented informed refusal following prognostic awareness. So obviously it's an informed refusal to continue life support. So there's a refusal to continue life support, either to start or stop the ongoing support. Compliance with procedure described by the Honorable Supreme Court. So this is what it is. And likewise, next, withholding is considered decision not to start an intervention that's unlikely to benefit or cause only harm in terms of suffering and loss of dignity. And the same 3 conditions apply. Next is, in the meanwhile, in 2020, the ICMR came out. It's a statutory body that came out with guidelines for DNAR. Do not attempt resuscitation. So we must understand that DNAR is not equal to withdrawal or withholding of life support. It is not doing CPR. It's a withholding decision not to do CPR. So it is included in the withholding decisions sanctioned by the court, but we also have additional endorsement by the ICMR. So a CPR which is not likely to help, you can foreclose as an option, because that's also, CPR is also a medical intervention. In 2023, as Dr. Keshav Goyal mentioned, we had this landmark judgment simplified, landmark judgment of 2018, which allowed withdrawal and withholding. They call it passive euthanasia, but this is what we really mean in modern terminology. Withholding and withdrawal of life support. So there is a simplification process from a more complicated to a less complicated. You can't really say it is simple, but it is less complicated than the 2018 procedure. Next. So this was followed by the latest position statement from the ISCCM, Indian Society of Critical Care Medicine, and Indian Association of Palliative Care, ISCCM, IAPC, position statement on end-of-life care and palliative care in intensive care units. So this was published in March this year. So you can see there's a large number of experts involved from different disciplines. It also includes a lawyer and a person from the ethics world, that is Dr. Roli Mathur from ICMR ethics section. So you can see that there is a 10-step decision-making pathway described in this extensive document of about 14 sections. Next slide. Now there are 10 steps which we will address one by one very briefly, so as to give you an overview of how we practically arrive at these decisions. Next. Of course, the starting point is a physician reflective prognostic assessment of potentially inappropriate life-sustaining treatment. So whenever we prognosticate, we also ask ourselves a question: is aggressive treatment appropriate here or not appropriate? So the prognostic assessment should be combined subjective and objective. Use of disease-specific scores alone are not enough, of course. The use of palliative care scores are also alone in themselves are not enough. We have to use our deeper understanding of the overall situation of the patient, and also exercise intuitive judgment, asking the surprise question: will I be surprised if the patient survives 6 months from now? Now, the answer is yes, that you will be surprised. Then that is a first step towards thinking about moving over to palliative care. Next step. Next slide. Yeah. So there are triggers for discussion on palliative care only option. There are about 10 such scenarios in the clinical world, such as catastrophic brain injury, irreversible severe neurological disability, and superimposed on that there's a critical illness, or there's a chronic irreversible disorders of consciousness such as dementia, minimally conscious state, or PVS, in which critical illness takes place, post-cardiac arrest, anoxic ischemic injury, which is not recovering after 3 days, advanced or metastatic malignancy with short median survival and no other treatment option, advanced age with declining functional status and frailty with repeated hospitalization, acute decompensation of chronic end-stage organ failure, again with no treatment options, including transplantation and repeated hospitalization, worsening multiple organ failure in an acute situation where so far score is more than 15 and reasonable trial of critical care has happened. And then any patient who has expressed a desire against aggressive care, it could be through an AMD, and then this surprise question. So these are, in a nutshell, the triggers for discussion for palliative care only option. Next. Second step is consensus of this assessment of appropriateness or inappropriateness of aggressive treatment. Particular inappropriateness of any intervention or escalation of intervention is consensus by the primary medical board, which can come out of the treating team itself. You know, in the ICU, always there are several specialists involved in each case and several physicians. So you have the primary physician and at least two subject experts with at least 5 years experience. Next. The critical intervention in EOLC decision making is the multidisciplinary family meeting. So one must, as a rule, have early and as needed multidisciplinary family meetings on clinical status, prognosis, and therapeutic options, including shift to palliative care only. Next. So once the treatment approach to palliative care only is considered and then explored, then a shared decision making for treatment limitation is done through listening, talking, understanding the family's perspective and clarifying doubts, and thereby combining the medical recommendations, beneficence and non-maleficence, with patient's choices or autonomy. Now, if the 95% of the time you can't approach the patient directly, so it has to be through the family or surrogate. If there is a valid AMD, there's advanced medical directive that has to be incorporated in the decision making. So communication in a nutshell should be candid, realistic, respectful, and sensitive. Benefits and burdens of each treatment or care option should be explored. Next. So teamwork is the key. So consistency of plan across the board in the team of providers, including nurses, should be ensured, and debriefing of all the team members should be done after each family meeting. Next. If there is no consensus, then we continue full support pending conflict resolution, which is done through expert opinion, consulting family physician, or non-medical decision support, such as a family elder or religious person. And then one can go back to step one of the pathway again and revisit the prognostication. Next slide. The Supreme Court makes it necessary for the approval of a secondary medical board, which is constituted by the hospital of three other physicians than the primary medical board. One of these physicians should be an appointee by the district CMO, Chief Medical Officer. This is again with 5 years of experience for the two subject experts other than the CMO appointee. Next. Once this SMB approves, then we can immediately implement, notifying the judicial magistrate of the first class. Only notifying, not waiting for any approval. Next. If there's no approval by the SMB, then we resubmit to the SMB with new justification for foregoing of life support, approach a clinical ethics committee if it exists in the hospital, and resolve differences between the PMB and SMB, or approach the court. Next. So obviously, once this decision and implementation is done, we move over to palliative care, which will address the physical, emotional, spiritual needs of the patient and family. We prioritizing patient comfort over avoidance of side effects of medication. We stop superfluous tests, liberalize visitation, display cultural sensitivity, allow non-intrusive religious rituals, non-abandonment should be expressed, therapeutic conversations should replace interventions, transfer to location of choice, providing professional caregivers adequate administrative support. Next slide. So grief and bereavement support is also part of our duties of care of for the family. Next. and review of the care process possible through having an ethics committee within the hospital for oversight, conflict resolution, and protocol updates. Next. So the key points of this presentation are the foregoing or life support decisions are complex, needing open communication, shared decision making, and transparency. Quality palliative care replaces curative treatment. In India, landmark Supreme Court judgments have validated patient autonomy and the rights to advanced medical directive and foregoing of life support. And recently, the Supreme Court has further simplified this process of executing advanced medical directive and implementing withdrawal and withholding. Thank you for your patient listening.
Thank you, sir, for that simplified version of end of life care. So it is moving again, as he has highlighted, that is moving from the treatment to the curative care to the basically palliative care, and take decisions in the best interest of the patient, taking care of all the principles of autonomy, beneficence, non-maleficence, and shared decision making. Withdrawal and withholding are almost the same. And of course, the current guidelines have made the official job, like the initially the district collector was involved and the judicial magistrate was involved, they have a lesser say. Now the hospitals and the medical fraternity have a more say, and it is the basically it is a two-tiered process instead of three-tiered process now. So now I will start the panel discussion with this. Now, in the end of life care, we are aspiring for the good death. Uh, what are the constituents of the good death? Dr. Sushma, ma'am, please.
So good death. I think death, when first time I learned about good death, even I was very surprised to know that good death exists when I first time in almost 3 decades back. So death can be good. This first time when I understood, I realized that this is so important. When end is inevitable, it is important that we must understand that when end is inevitable, it should be very, very comfortable. It should be dignified. It should be with your loved ones. It should be a place where you like the most, and it should be without pain, without any suffering. And this can be provided by good palliative care, where everything is like we have taken care of our cultural, religious, or spiritual requirement, where my autonomy is being already respected. When my all the unfulfilled work I have finished, I think this is when end, I think that end is inevitable, and everything which I wanted to finish has been done. It is pain-free death. It is a good death. I think this is the good death, without any monitors, without any vasopressors, without any ventilator, away from with my loved one, not away from my loved one in ICU.
Yes, ma'am. So good death, it is physical, spiritual, and emotional. Basically, all the components are simultaneously merged together, and the patient is basically, it is a celebration rather than death is again a celebration. Like it is a fundamental right, and it should be celebrated. So, ma'am, the next
ideally
question.
Ideally, death should not be a stigma. It should be an enigma. People should start celebrating death because it is ultimately inevitable sometime.
Yes.
Thank you, Keshav. Yeah, go ahead.
So next comes the how to basically there are situations like catastrophic brain death, and there are many terminal ill. But are there anything that we can prognosticate accurately and precisely? Sushma, ma'am, I would like to ask this again to you.
So actually, this we are practicing since last many years, and it is not a very tough job. Basically, only thing you have to know your patient well. So first you have to understand your patient well, and if you have understood patient well and you know that there is a major brain damage has happened, major organ damage has happened, and it is there are hardly any chance, or there are no chance of prolonged survival, and whatever we will do for this patient, catastrophic brain injury patient, it is going to increase his suffering. I think this is a time when, the as Dr. Mani has given the 10 steps, but I will say that next step should be, we should start talking to the family members. And this is a very good practice, that we should call the all the important family members together, because one person come one time, second person will come second time. I think in our conversation also, they understand the meaning differently. So it is always better what we do, that we call all the family members together with one of our colleague who is also convinced with the decision, and sit down with the patients and their relatives. They also understand. I think, according to me, the patients and their relatives are very brave. If you will make them understand properly, they will listen to you, they will understand, and probably they will understand better than what other people understand in the medical fraternity. So it is important that we should understand first, know your patient first, and to call the relatives and loved ones, and make them understand, and start end of life care, rather than don't desert the patient, because these people don't want to be deserted. We can't say that we can't do anything because there is a catastrophic brain injury. You do whatever, you go home or something like this. Even if you are sending home, there should be a plan for the patient, and there should be a communication channel should be open. Then only they will feel empowered, and we will be able to explain them properly.
Jiten sir, how do you prognosticate your patients?
So, prognostication most of the time looks very simple and easy, most of the time, but sometimes it's really very difficult. Occasionally, we also experienced, in the literature is also mentioned, the conventional method like GCS at the 72 hours may not be a really very foolproof method over there, though the routine practice is like if somebody remain GCS 1 or 2 at 72 hours, it appears to be a very devastating outcome or severe brain injury. But most important thing, apart from the individual scientific facts, as Dr. Shushma ma'am mentioned, the context and the pretext is very, very important. If those patients under the care of the same clinicians over the weeks times or maybe a year's time, then probably things becomes a reasonably easy for them. If suddenly you are exposed to those patients who apparently having a devastating neurological injury, then probably few patients, the literature already said the GC is not enough. Now every time you can't go for the functional MRI or maybe SSEP. All these things good in the literature. These are the few things you can take the help, but not on the practical or on ground kind of this thing is. These are the specifically for the neurological. Now comes to the things again, looks simple in malignancy, but sometimes it's not that easy. Say for example, a metastatic malignant disease which patient is having, this time he presented with the urinary tract infection, probably with the shock, and you don't know your routine care which you do a sepsis early management of the sepsis and the antibiotic appropriate antibiotic therapy. He or she can make it for the some time with the reasonably again good health status. So just labeling them as somebody is having a malignant disease and comes to the acute care or the critical care will be entitled for the end of life. No, it is not that much easy. That's why we require a full training. Until you are not very sure, then you will give your benefit of doubt. But with rider, these are the very small proportion of the cases. So don't overemphasize on this thing and withholding your support or the starting of the end of life in otherwise a very, very straightforward, and by your medical knowledge, by your common sense, and by your a general way of management, this is the person who is eligible for the end of life. And that's why I think we are gradually maturing in that sense, and I think that is the one reason uh, judiciary and as well as the all the medical fraternity keeping things in the stepwise, and let's see how the things will happen. That's why we are having a primary medical board and maybe a secondary medical board to over the time period, so that we can really gauge what is happening when we are practicing end of life.
Yes, sir. So now I'll bring Dr. Kritika into the picture. So now dealing with the specifically neurocritical care scenarios. So how it is separate from a cancer patient who is having multiple secondaries, and he is in old age and he is already having multi-organ disorders. At the same time, we have a second patient which is having a devastating or catastrophic brain injury. So how are they two different? Are all catastrophic brain injuries the candidate for end of life care? What's your take?
Thank you, Dr. Keshav Goyal, sir, and a very thank you so much to have me here. And this is one of the most important questions that we see when we see in oncopalliative care. The trajectory of the patient, the kind of patient population we see itself is very different. The trajectory of the illness may, for some of them who are upfront metastatic, depending upon the biology of the cancer and the disease burden, the trajectory could be very short in matter of few, weeks to months. Whereas in patients here, when we see in the neuropalliative care with the varied neurological injuries, like it could be a SABI, in a catastrophic brain injury which you mentioned, or it could be in patients with stroke. The kind of trajectory is so varied. The kind of patient that we will see is what is one of the most important differing things in aspects when we consider between these two things. Along with that, one most important thing is the kind of needs that these patients will have. In oncopalliative care, there will be more of in terms of high symptom burden because primarily disease related, treatment related. But in terms of neurological illnesses, it will come in terms of there'll be a lot of understanding in terms of what it really means. I read about this long back when we are trying to talk about the course. Is in neurological illnesses, if a patient who has a capacities to understand thinks that something is intrinsic to them, whereas person with a cancer feels that the cancer is something like an external entity that they have derived in. So that is how they perceive the illness in itself in the first place. And when we see looking at patients with neurological illnesses, and especially in the context of catastrophic brain illness, looking at the difference here, there is no formalized or standardized way how we can identify these patients who really need to be immediately for end of life at the first instance. Like somebody who has just come in, it's not even 24 hours, and the neurosurgeon says we cannot operate, and put them into the ICU, and there's nothing that more can be done, refer to palliative care. I think as per the literature, the evidence at least asks us to wait for 72 hours before we can ever even conclude that this patient may not have any significant recovery. And in that also, based upon the characterization of whether it's a mild injury or a moderate to severe injury as per the impact, based on that recovery, in some of the literature has also showed that patients do have some minimal cognitive state achievable after 28 days, or after 2 to 3 months. So it is in this situation, we should also have this understanding that upfront we may not be able to characterize them, but at least looking at a time limited trial in these cases, where having a discussion with the family, the surrogate decision makers, if the patient is not in the state to take that, or there is no prior advance directive or a care plan that has been documented in the previous visits with the primary team, and that could help us in the future to make those plans, sit down and make a better shared decision make with the surrogates. So I wouldn't say that all catastrophic brain injuries are for end of life. We need to have like a structured plan, and patient to patient, case by case, what are the preferences of the patient, and the values that what achievable quality of life is, what the family is looking towards, what is acceptable to them in that state of mind. Sometimes we see looking at like a paradox where our perception of what is quality of life for this patient will differ to what the perception that the family or the surrogate decision makers have for them. So that is very important for us to come to a consensus together and then decide when should we initiate end of life care measures for such patients.
So, like for the generally, we have the assessment tools we have for the oncopalliative care. Generally, the whatever but there are none for the neuropalliative care. So, can you briefly do what we can do and how we can go ahead with that?
Yes. In when we look at needs assessment for palliative care, now a lot of literature is derived from oncology because that is how it initially started first with. So we have some few tools which talks about which is a PC scale, which is a needs assessment tool palliative care. Now this has like a multi-domain scale where we look at the patient's aspects, like in terms of what physical problems they will have, in terms of certain neurological illnesses where like stroke, dementia, Parkinson's, what is the kind of psychological morbidity is that the primary illness leading to, ability to care for themselves, is there any spiritual or existent distress that they have. So this is these are components of the patient aspect. From the caregiver domain, they looked at how well are they able to care for the patient, are they able to look after well, how many hours they are available, what is the support structure that they have. So these all components come under the needs assessment tool for palliative care support. So that helps us one way also if we do it as a screening measure for these patients who are with a neurological illness where the trajectory or it's a progressive illness. If we start using this as a screening tool, that can help us identify these patients early, so that discussions on advanced care planning, symptom management, care preferences all can be initiated.
Hmm. So, I'll go to the Dr. Jitendra. So, what are the differences basically we see, and what are the barriers we see while practicing quality end of life care in India? So, what are the barriers we find?
So, barriers, of course, it can vary from one region to another region and from one institute to another institute. Few are the common, like first and foremost is the legal clarity. So that is the most important barrier. It may be, to some extent, it may be a real, and most of the time it is a perceived one. Only those who are really take up the palliative care and end of life care objectively, they are a little bit more aware about the what are the changes happening in the legal process of the end of life care in the India. But in general, all the doctors, because that is the universal thing, it happens everywhere. So all the healthcare personnel may not be really having a legal clarity over there. And of course the real problem, like forming of the primary medical board is very easy for the individual institute, where they can have a subject expert also. But then approaching to the secondary medical board, to the government functionary, we know that would be, anyway, there are so many things in their hands, so many things happening around them. This becomes a little bit, you can say, it take a back step over there for actively involvement on the end of life secondary medical board formation. Then comes to the in general society awareness. Even the doctors, nurses, they come from the society. In general, the society awareness about the death is not really very well understood emotionally, spiritually, though certain religion, like in Jainism, Santhara kind of these things are there. They are having some understanding. If you leave that, then the most of the things are not there. Even in our a basic education, nobody talks about the death and how to face that, how to approach the death, in what conditions. Nobody like to discuss among the family members. And suppose the even all this comes in a very very small proportion, even we match all these things, people start, then the lack of training. So people are not really very well trained. We despite we are knowing, I'm a true on the ground kind of a practitioner. Even if you initiate the end of life, so most of the time, even reflexly, people come to the patient and the immediate we need not to do anything for this patient. This is patient for the end of life. We need not to do anything for the patient. So we are having a pessimism of there, rather than this is the one of the modality we have to do something for the patient rather than not to do for the patient. So that requires training. So that is also lacking for the and resources. Typically in general, and we are having a very heterogeneous healthcare system. Few are the government sponsored, then the TPA, and they're ceiling on the TPA, and then out of the pocket expenses. In general, you talk about the resource allocation or consumption of the resource, if directly from the out of the pocket from the patient, and spending on the person for the dying person and the getting the death taken as you may take it as it's a completely futile, especially when it comes to the out of the pocket, so that people may adopt a different pathway. Still in the medical practice, we are in general we are very much afraid about the media trial. So in general, doctors are also reasonably skeptical about the media trial. Also, nobody knows what happens afterward. So these are the few challenges which I feel there may be a variation from one region to another region. There may be a many more over there. These are the common which I understood over the last 10, 12 years. Obviously, it's gradually more acceptable, but it's very meager. It's a very small component we are talking.
Actually, again, the awareness and the teaching more and more of basically talking about end of life care is going to be the way forward, and basically, so the barriers will move away.
I think at least if we go for the consistently brain dead declaration with or without organ transplantation, that would be even the first step, because that is having a clear cut scientific
Criteria.
way as well as the understanding. If we achieve uniformly that, if every hospital is actually starting declaring the brain death with or without organs transplantation, then the next things we can talk about that.
Correct. So actually, Dr. Mani sir has already talked about the 2023, which was a simplified where the limited role of officials is there and hospital get more say. And now the 29th September, the health ministry also announces the draft guidelines on passive euthanasia. So now the government is also taking in. So I think the effort of Dr. Mani, Dr. Sushma, and all the stalwarts is taking shape. I think they are slowly, of course, it has taken a lot of time, but they are taking shape. And the summary is, of course, it is a time bound now, and the changes have taken from the what was there in the 2018 to 2023. So I would ask Dr. Kritika, so what are the major differences, if you can summarize for the audience, basically, from the 2018 judgment versus the 2023 judgment?
Yeah, thank you. So the 2018 judgment, it was about, then it had given a guideline about, the advanced medical directives. And in the judgment, then it was that a judicial first class magistrate has to be the one who executes it. And that was one of the major challenges noted in the next 5 years. And that is why in 2023, it was changed to that anyone who's a gazetted officer can execute that before a notary or a gazetted officer and get that officially put in. And one of the major things was that this document was only going to be accessed at the court. They were the ones who were going to be holding it. But then it was later in 2023 changed that even the one hospital record could be filed in, patient can have a copy, give them to their primary physician, keep it all across in their health record so that it can be accessible at any time, and there is no discrepancy, or the surrogate decision maker who is appointed, if they have been noted in that, also has a copy kept so that in case of need, they have it available to be given to the physician whenever the patient reaches a state where they're not able to make a decision for themselves. Also, one of the major points that was there is the formation of the first primary board that was coming in. It was initially told that at least 2 experts, subject experts, but with a vast 20 years experience. Now, every hospital, to be able to have that 2 experts with that vast experience was a difficulty and a challenge, which was modified in a 2023 judgment to have at least 2 subject experts with more than 5 years of experience. And that would comprise of the 3 people with a physician and 2 other subject experts involved into that. And later on, another additional point that came up for the secondary medical board was that initially in 2018, it was the district collector or the district medical officer has to constitute that board, and then decide upon with the subject experts what needs to be done ahead. But there was no ceiling effect of the time limit that the primary and the secondary board could take. Later on, they came up with in a 2023 that within 40